today. We're very privileged to have Associate Professor Colm Travers from Alabama staying up very late at night to talk to us. But it's summertime there, right?
That's right.
Yeah,
Yeah, summer.
summertime, so it's probably still light. So Colm is originally from Dublin, and he said, the last 12 years in Alabama. He's a neonatologist, and he's the assistant director of their neonatal fellowship program. So he's the person to ask if you want a job in Alabama. So we heard Colm speaking at PAS this year in the therapeutic drift session on a very, very important topic, permissive hypercapnia. So I hope, I'm so glad that you have agreed to talk to us. The Zoom session will reach many people everywhere. Some of them may not be able to join because of time zones, but they will slowly start drifting in. And if you could leave about 15 minutes at the end for people to ask questions, that would be great. And apart from that, that's all the housekeeping. And the floor is yours. Thank you so much.
Hey, thank you so much for the invitation. It's such a pleasure to talk to this group and to be presenting on permissive hypercapnia and how high can we go. So I do have a financial disclosure that I have a grant from Owlet Baby Care for an investigator-initiated research grant. But I'm not going to discuss anything to do with that in this talk. So first I wanted to touch upon the clinical rationale and historical context which led to the development of permissive hypercapnia in neonatology. So traditionally, neonatologists targeted normocapnia with carbon dioxide values ranging from 35 to 45 and with normal pH values from 7.35 to 7.45. And while there were no data to support this practice, it was commonly assumed to be the best practice for neonates to keep them in a normal range. However, it was noted that maintenance of normocapnia in infants with severe respiratory failure necessitated higher ventilatory support to maintain alveolar ventilation. In addition, early work on the mechanisms responsible for control of breathing in infants found that preterm infants had altered apneic thresholds and needed a higher carbon dioxide level to trigger breathing and a flatter slope in terms of increasing alveolar ventilation, indicating that sensitivity to carbon dioxide differed among preterm infants. So preterm infants with apnea are known to have altered chemoreceptor responses to hypercapnia with higher alveolar carbon dioxide and a flatter slope on the carbon dioxide response curve. So a change in ventilation for a change in carbon dioxide. So this figure shows that preterm infants with apnea do not increase minute ventilation until the carbon dioxide rises significantly. And even then, their response to carbon dioxide is less than among infants without apnea, who are more tightly control their carbon dioxide levels. In addition, preterm infants have an imbalance between the hypercapnic thresholds of respiratory muscle groups, with higher thresholds in the upper airway muscles compared with muscles of the posterior cricoretinoid and diaphragm, which may contribute to upper airway collapse and apnea. So carbon dioxide insufflation, or the therapeutic use of carbon dioxide, has been shown to decrease apnea in preterm infants. So carbon dioxide insufflation was tested as a way to increase minute ventilation and reduce apnea in preterm infants. In a double-blind, placebo-controlled randomized trial of 87 preterm infants with significant apnea, metylxanthines plus 0.5 liters per minute of room air via nasal prongs were compared with placebo plus 0.5 liters per minute with 1% carbon dioxide through nasal prongs. And both groups had a significant reduction in apneic episodes compared to baseline. However, the metylxanthines were superior to carbon dioxide inhalation. But overall, this study demonstrated that therapeutic carbon dioxide, or giving babies carbon dioxide through a nasal cannula, decreases apnea episodes and increases minute ventilation in preterm infants. So you may well ask, how important is the effect of carbon dioxide in terms of lung protection in babies, given that we know that volume trauma is the primary mechanism of lung injury due to mechanical ventilation. So, for example, in this famous animal studies, strapping the chest of mechanically ventilated dogs to decrease chest rise and volume changes prevented lung injury in spite of high pressures. So if you used high pressures without the strapping, you had a lot of pulmonary edema, pulmonary epithelial injury, hyaline membranes. But if you use the strapping with even with really high pressures, by avoiding that change in volume, you didn't really see that pulmonary edema or epithelial injury or hyaline membranes.
Excuse me, Colm. Were you going to share your slides with us?
Oh, so you can't see the slides
No, I
changing?
can't see. We can't see your slides. Yeah, so sorry.
No,
Yeah.
that's
Uh-huh.
a pity. I don't know. Yeah, it doesn't work yet. It looks like
Yeah.
I'm sharing. So what do you see right now?
Nothing. Just you. You're speaking very well.
Oh, that's weird.
Yeah, I see them though. I can see the slides. So maybe Julie, it's
Okay.
just you.
Mm-hmm. I can. Oh, everyone else can. I can't see the
Yeah,
slides. Ah,
yeah.
right. Colm Travers screen. Yeah, there's another one. So sorry. Yeah.
Okay.
All right, that's good. I'm glad.
Apologies.
I'm
Yeah.
glad you can see the slides and I didn't just go
Sorry.
for
I had two screens for some reason.
you're very polite not to say anything for 5 minutes.
No, that's okay.
All right, I'll keep going. So where could permissive hypercapnia fit within this equation in terms of lung protection? So given the data that hypercapnia improved control of breathing, I'm getting a bit of a reverb there. Does anybody else hear that? Somebody have their meeting mute,
Yes,
please.
it's a reverb. Yeah. Oh, that's better. Yeah, it's gone. Mhm.
There we go. So given that hypercapnia improved control of breathing and that mechanical ventilation caused lung injury, clinicians began to consider allowing some permissive hypercapnia in order to limit the intensity of mechanical ventilation. So the concept was that if you use a lower tidal volume to protect the lungs, you're going to have less CO2 elimination, which leads to hypercapnia. But if you increase the ventilator rate, it's relatively inefficient at removing the carbon dioxide, so you're going to have some hypercapnia. But in terms of the intensity of alveolar ventilation, the amount of ventilation needed to maintain normal capnia is approximately 50% higher than that which you would need if you were allowed some mild, if you want to maintain some mild hypercapnia. So by avoiding normal capnia, you're really able to use less intense ventilation, allows you to practice using lower tidal volumes, and then you can just use the rate to compensate. But again, knowing that the rate won't fully get rid of all your carbon dioxide. So there was also some observational data coming out in the 90s about the risk for BPD in infants with RDS. And this emerging data reported an association between lower CO2s and a higher risk of BPD among infants with RDS, which seemed to be dose dependent. So in infants with PCO2s less than 29 compared with greater than 40, the odds ratio was 5.6. And infants in the 30s compared with those in the 40s, the odds ratio was 3.3. So it seemed like a dose-dependent effect, and it seemed like it was quite a strong effect as well. It was similar to the effect of having a birth weight less than 1,000 grams in that study. So meanwhile, there are also several basic science studies reporting on the potential protective effect of hypercapnia in animal models. So in this animal model study, hypercapnia decreased lung injury scores from volume trauma in adult rabbits. So here we saw that in the eucapnia group, they had higher levels of interstitial edema, alveolar edema, higher rates of mononuclear site infiltration, and higher rates of hemorrhage. So overall, higher injury scores with eucapnia compared with hypercapnia. And therapeutic hypercapnia are actually giving carbon dioxide decreases pulmonary and systemic injury in ischemia reperfusion animal models. So here in the therapeutic hypercapnia, so these are animal models where they actually are giving carbon dioxide, it seemed like there was, again, a protective effect of therapeutic hypercapnia. And again, here in this study, giving extra carbon dioxide decreased endotoxin-induced lung injury in animal models. So this is like an LPS animal model with therapeutic hypercapnia. And therapeutic hypercapnia also reduced lung injury in chronic hypoxia models in newborn rats. And then they moved on to kind of more familiar maybe animal models for some folks in preterm lambs, and they found that hypercapnia improved the compliance and lung volume in preterm lambs. So again, targeting that higher carbon dioxide level seemed to improve the lung function. However, there are also data emerging about potential risks associated with using permissive hypercapnia. So, for example, permissive hypercapnia increases pulmonary shunts in adults with ARDS. We know that extremely preterm infants have impaired cerebral autoregulation, making cerebral blood flow pressure passive and sensitive to carbon dioxide changes. And this figure shows that as carbon dioxide rises, the mean cerebral near-infrared spectroscopy values increase. So hypercapnia causes cerebral vasodilation, which increases cerebral blood flow, which can risk hyperperfusion and interventricular hemorrhage if excessive or rapid. And sustained cerebral blood flow changes from acidosis or inflammation may impact the white matter and synaptic development, which might affect longer-term outcomes. And there was also observational data that rapid carbon dioxide changes, whether too high or too low a carbon dioxide, or what we might call non-permissive hypercapnia, was associated with interventricular hemorrhage and or periventricular leukomalacia. So there are also some other studies looking at potential adverse physiologic effects of hypercapnia. So with hypercapnia, to summarize, hypoxemia, because you might get hypoxemia because you have an increased carbon dioxide and increased pulmonary shunting with higher carbon dioxide levels. You also might have decreased oxygen uptake by hemoglobin because of the shift to the right of the oxygen dissociation curve. It can also cause vasodilation, which is especially concerning in the preterm brain. And you can also have an effect from hypercapnia and acidosis on myocardial contractility. So myocardial contractility is impaired during acidosis, especially if the acidosis is severe. But there are quite limited data about that in neonates. So at this point, there were important questions about the efficacy and the safety of permissive hypercapnia, and there was a strong need to conduct clinical trials. So we knew that mechanical ventilation causes lung injury via primarily volume trauma, but also barotrauma and oxygen toxicity, especially in immature neonatal lungs. And we also knew that prolonged mechanical ventilation is common in extremely low birth weight infants. For example, here we saw that the median number of days mechanically ventilated, 23 days, was associated with a higher risk of BPD among infants who had prolonged mechanical ventilation. So the first trials of permissive hypercapnia were actually conducted in adults with ARDS, and they demonstrated lung protective ventilation, accepting higher carbon dioxide levels as part of that strategy to limit the tidal volumes to 6 mLs per kilo, compared with a strategy that used less or equal to 12 mLs per kilo, reduced adverse outcomes. And so these trials here show that after 53 adults were enrolled in the first trial, and this published in the New England Journal of Medicine, there was a 38% mortality in the protective lower tidal volume permissive hypercapnia group versus 71% in the higher tidal volume normal capnia group. And the rate of barotrauma was also lower in the protective group. And so here we can see that in the protective group on the survival curve, that there was a significant difference in survival, even in this small first trial in adults with ARDS. So this led to the first trial of permissive hypercapnia in neonatology, which was conducted at the University of Alabama, Birmingham. And this included 49 infants from 601 to 1250 grams who were intubated and ventilated for RDS within the first 24 hours after birth. And the intervention group in this study used a carbon dioxide level of 45 to 55 and with a lower limit of pH of 7.20. And that was compared with a carbon dioxide level of 35 to 45 with a pH control level of 7.25. And this was done for 96 hours after randomization. And again, similar to what we talked about earlier, priority was given to limiting the pressures or the volumes and using higher rates for carbon dioxide control. And the median number of days ventilated was 2.5 in the intervention group, compared with 9.5 days in the control group. So a significant reduction in the number of infants who were ventilated in the 96 hours after randomization. And you can see here that there was a reasonable separation between the groups, with the 35 to 45 mostly hovering around 40, and then the other intervention group getting up to around 50. However, there was no significant reduction in BPD or air leaks or use of postnatal steroids, although of course this was a small study, pilot study of only 49 infants. So this was followed by a NICHD Neonatal Research Network multi-center randomized trial of permissive hypercapnia, which included 220 infants from 501 to 1,000 grams who were intubated and ventilated before 12 hours after birth. So this study used CO2 limits of 52 in the treatment arm and less than 48 in the control arm. So there was a 4-point separation of carbon dioxide between the groups of study, and the minimal ventilation group generally achieved these higher carbon dioxide levels among infants who remain ventilated beyond the first week. And among infants who were randomized to higher carbon dioxide, there was a significant reduction in the number of infants who were mechanically ventilated at 36 weeks, which is equivalent to the definition of grade 3 BPD that we use today. Differences in the risk of any BPD and or death were not significant overall, but there was a significant difference among the smaller infants from 501 to 750 grams, where they had a 68% risk of death or BPD versus 86% with a CFMP value number needed to treat of 6 infants. So after the initial success of these kind of pilot study followed by that larger SAVE trial, there was a further single-center randomized trial, again conducted at UAB, of infants from 23 to 28 weeks gestation who were intubated and ventilated within 6 hours after birth. In this trial, the idea was that they were going to use a larger separation between the groups. So in the treatment group, they planned to set a CO2 of 55 to 65, and in the control group, they planned a CO2 of 35 to 45, so normal capnia versus a higher level of permissive hypercapnia in that first 7 days after birth. But the trial actually ended up being stopped at 31% enrollment when only 63 infants had been enrolled, because the interim analysis showed that there was a trend for higher mortality, 36% versus 19%. There were no significant differences in BPD or death or BPD, and there was no difference in IVH, but there was a higher risk of motor impairment or death at 18 to 22 months in the higher group. In this study, there was a 6-point carbon dioxide difference achieved between the groups, but it was noted that the pressures and tidal volumes that you can see here on the top figure, that there was no difference in the pressures used in between the groups. And also there's no difference in extubation between the groups, suggesting that the goal of using permissive hypercapnia to reduce the intensity and decrease exposure to volutrauma and barotrauma and mechanical ventilation in general was not achieved. So it was also possible that the pH control required in previous trials limited the separation between the groups, as infants were yet to develop enough pH compensation to allow for some of those higher levels of permissive hypercapnia. So it wasn't clear whether the pH control was important or just carbon dioxide. So to answer this question, the Felby trial randomized 362 infants from 23 to 28 weeks gestation who were intubated and ventilated in the first 24 hours after birth to higher or lower levels of carbon dioxide with no lower limits for respiratory acidosis. So in the Felby trial, they used a higher level of PCO2 from 55 to 65, which then increased to 65 to 75 millimeters of mercury. In the lower group, they used the PCO2 of 40 to 50, which increased to 50 to 60. So both groups were really receiving permissive hypercapnia. The one was receiving a lower level of permissive hypercapnia, the other one receiving a higher level of permissive hypercapnia. And again, there were no lower limits, pH limits for respiratory acidosis in that study. This trial did achieve some carbon dioxide separation between the groups as shown in the top figure. But again, there was no difference between groups in the proportion of infants who remained intubated and mechanically ventilated over time. And there was no significant differences in rates of BPD or death, so 36% in the higher group compared with 30% in the lower group. But it was noted that the neck rates were higher, so there was a 12% rate of neck in the higher permissive hypercapnia group compared with 5% in the lower permissive hypercapnia group. The reasons for this difference were not clear. It's possible it could have been due to chance, or it could have possibly been related to the lack of pH control that was used in this study. So as in previous studies, there was no difference in IVH, and reassuringly in infant development at 2 years old also did not differ between the groups in the Felby trial. So to summarize these clinical trials, initial studies targeting modest early hypercapnia with pH limits reported decreased number of days ventilated and decreased need for mechanical ventilation at 36 weeks postmenstrual age. The higher carbon dioxide targets without pH limits
That's all good.
reported no benefits for BPD or death and possibly an increased risk of neck. So meta-analysis of these trials are shown in the forest plot here. So we can see that in these four trials that I just discussed, that there's no effect for BPD risk in extremely low birth weight infants who receive permissive hypercapnia versus control. So the difference was not significant with a risk ratio of 0.93 and confidence intervals that included 1. Showed no clear benefit for BPD, so this supported equipoise and the need for further randomized clinical trials. But what about the early CPAP trials? So it's often overlooked that both the support trial and the VON trial included carbon dioxide and pH targets as part of their bundle to avoid or limit mechanical ventilation, but these studies were not included in this meta-analysis. So in the support and the VON trial, early routine CPAP was combined with permissive hypercapnia using a carbon dioxide level of up to 65 and a pH limit of 7.20 as the lower limit. And this was used as part of the bundle to avoid or reduce exposure to mechanical ventilation. So here we see in the studies like support, the DON trial or VON trial and the support trial with the routine application of CPAP that again included permissive hypercapnia, that there was that it favored selective surfactant compared with prophylactic surfactant. So these trials showed that this strategy of early routine CPAP with permissive hypercapnia reduced chronic lung disease or death, compared with the control group who received prophylactic surfactant and mechanical ventilation and used an upper limit of 50 for the CO2 in the control group. So as a result of these clinical trials, permissive hypercapnia found its way into daily clinical practice in neonatology. So for example, in an observational study of over 1,500 blood gas results in European neonatal intensive care units, this was published in 2013, carbon dioxide levels more than 52 was common after the first week after birth, so 43% of blood gases had a PCO2 higher than 52. And higher levels of carbon dioxide were noted in infants who were managed with volume control ventilation, suggesting that this was a move towards permissive hypercapnia as part of lung protection strategies. And then influential neonatology groups such as Vaughan, Brettsaber's QI Collaborative started to recommend permissive hypercapnia as part of their bundle for gentle ventilation to reduce lung injury. So therefore, permissive hypercapnia was being used routinely in neonatology, but there was really limited evidence about the use of permissive hypercapnia beyond the first 7 to 14 days after birth. So to address this gap in the literature, we conducted a randomized trial of 130 preterm infants with respiratory distress syndrome who remained ventilated from postnatal day 7 to 14. So the higher group in this study targeted a CO2 from 60 to 75 millimeters of mercury with a lower pH limit of 7.20 or higher. And the lower permissive hypercapnia group in this study used a CO2 target of 40 to 55 with a lower pH limit of 7.25. So we had limited separation between groups in terms of carbon dioxide in this study, and we noted that most infants who are breathing spontaneously will keep their CO2s in the 50s. So what we found is that we could wean them faster and extubate them sooner, but they would just breathe more to compensate. So higher levels of using higher levels or targeting higher levels of permissive hypercapnia increased the number of days that infants were alive and ventilator free in the first 28 days by 5 days, with an average of 11 days alive and ventilator free in the higher group compared with 6 days alive and ventilator free in the lower group. Secondary outcomes such as mortality, grade 2 to 3 BPD, the composite of grade 2 to 3 BPD or death, postnatal steroids for bronchopulmonary dysplasia, didn't differ between groups, but the direction of effect for these outcomes was reassuring. The interesting thing was that BPD associated pulmonary hypertension, although it didn't differ, the direction of the effect went in the opposite direction to grade 2 to 3 BPD. And we thought that was interesting because usually you expect pulmonary hypertension and higher grades of BPD to kind of travel in the same direction. So again, there were reassuringly no differences in neurodevelopmental impairment at 2-year follow-up, suggesting that there were no obvious safety concerns for longer-term outcomes using this strategy of later higher permissive hypercapnia in preterm infants who remained ventilated after the first week. So what are some practical applications of these data, and where are we left now in terms of our future research directions? So accepting a higher carbon dioxide level can help avoid or reduce mechanical ventilation exposure, which may improve pulmonary outcomes. And it's interesting that this is now really commonly practiced. Preterm infants will usually increase their minute ventilation to maintain their carbon dioxide levels, and that makes separation challenging when you're doing these clinical trials. So often when we wean the carbon dioxide, level doesn't actually change after we make the ventilator change. So we can keep weaning the babies more aggressively if we know the carbon dioxide level is in an acceptable range. So this strategy of using permissive hypercapnia alongside lower tidal volumes can be aided by transcutaneous carbon dioxide monitors, which, while they are not always perfectly accurate, they are extremely precise. So they can be used to facilitate faster weaning and avoid large fluctuations. So with these data in mind, there was a new European survey of over 400 neonatal intensive care units in 24 countries, which reported that 60 to 90% of units were using permissive hypercapnia with levels higher than 55 millimeters of mercury, depending on the infant age and level of respiratory support, suggesting that higher levels of permissive hypercapnia are now accepted and have really become embedded into clinical practice in neonatology. However, I think it's fair to say that there's still a lot of room for further trials. So there's really limited high quality evidence to support the different levels of permissive hypercapnia that are being used in clinical practice. In terms of the clinical outcomes in the clinical trials, we should really consider targeting pulmonary important outcomes that are most important to families. And I do think that alive ventilator-free days is considered an important short-term outcome for families. Unfortunately, they don't generally think of BPD as being an important outcome, but yet many of our trials have planned around rates of bronchopulmonary dysplasia. So we really need to think about what short-term clinical outcomes are we going to target when we do these future trials of respiratory interventions in preterm infants. And then the other thing that's often lacking is longer-term outcomes, because parents care potentially more about, for example, the need to go home on oxygen, the effect on longer-term lung function and fitness, as well as the impact of post-prematurity respiratory disease on the child and the family and how the child can function. The other question is which population should we be testing in future clinical trials? So most trials to date have focused on extremely preterm infants at risk for BPD in the first 7 to 14 days after birth. But as far as I know, there are no trials focused on infants with established bronchopulmonary dysplasia. So currently we're really practicing in a vacuum when it comes to these infants with established BPD. So despite the lack of clinical trials, including infants with established BPD, there's evidence of therapeutic creep in the expanded use of permissive hypercapnia to infants with established BPD who are not included in the randomized trials of carbon dioxide that I've mentioned. And they are often using carbon dioxide limits that are above the limits that we use in the trials. So I replaced Lindsay Lohan here with Wally Carlo, as he's probably the key investigator when it comes to permissive hypercapnia neonatology. And he was a senior investigator on the trials at UAB. He also trained Ulrich Dome at UAB, who conducted the Felby trial, and he led the SAVE trial and the support trials. And if you asked him today, he would probably tell you that the limit for carbon dioxide in infants with BPD does not exist, as he focuses mostly on the pH and the compensation. But this is still clearly controversial, as many textbooks focus on much lower levels of permissive hypercapnia, such as levels from 40 to 55 or 40 to 60 still. So is a fair question is, are there carbon dioxide limits or just pH limits when we're talking about permissive hypercapnia? We've also reported an association between carbon dioxide levels and BPD-associated pulmonary hypertension, but it's not known if we should change the targets if there is pulmonary hypertension developing in an infant. And it's also possible that higher levels of permissive hypercapnia could actually increase the risk of pulmonary hypertension. But we have, again, very limited data about the risk of pulmonary hypertension from this strategy. So there are also limited data on using permissive hypercapnia in other neonatal populations. So in infants with congenital diaphragmatic hernia, higher initial carbon dioxide levels were associated with higher mortality and a higher use of ECMO. But in pre-post studies, permissive hypercapnia, when used again as part of a strategy that included targeting minimal tidal volumes and using higher ventilator rates to compensate, was associated with lower mortality and a lower use of ECMO in infants with congenital diaphragmatic hernia. In infants with pulmonary hypoplasia due to other causes aside from CDH, there are really limited data, but some use the same strategy that I just mentioned that people are employing in infants with congenital diaphragmatic hernia fairly routinely now. So the use of permissive hypercapnia in infants with persistent pulmonary hypertension in a newborn is pretty controversial because of, again, of that risk of potential for increased risk of shunting in babies with PPHN. And there are limited data reporting on the use of permissive hypercapnia in infants with congenital heart disease. But the AAP guidelines for respiratory care in infants with congenital heart disease do recommend considering mild permissive hypercapnia in preterm infants if respiratory distress syndrome is complicating their illness. So for clinical practice, neonatologists can accept a higher carbon dioxide level to reduce the intensity and the duration of mechanical ventilation, but randomized control trials suggest it is important to maintain pH control. So our best evidence so far suggests that keeping the pH level of 7.20 or higher is a reasonable approach. However, this doesn't necessarily imply that we should use bicarbonate or acetate to achieve the pH control so that we can then use higher carbon dioxide levels. There's no evidence of increased risk of intraventricular hemorrhage or neurodevelopmental impairment from trials of pH-controlled permissive hypercapnia, which provides some reassurance about the safety of this approach. However, pulmonary hypertension may affect the tolerance, and it is possible that permissive hypercapnia could even increase the risk of BPD-associated pulmonary hypertension, but further research is needed in this area to understand the best upper limit for infants with BPD who are at risk of pulmonary hypertension. Non-permissive hypercapnia with large sudden fluctuations in carbon dioxide should generally be avoided, as this may increase the risk of intraventricular hemorrhage in extremely preterm infants during high-risk windows. So the best approach overall probably involves careful monitoring of tidal volumes and continuous transcutaneous carbon dioxide monitoring with frequent ventilator weans as tolerated to minimize your volutrauma, to minimize your mechanical ventilation exposure, and hopefully to reduce lung injury. Thank you very much again for the invitation, and be delighted to take any questions from the audience. I'm going to stop sharing.
Okay, thank you so much, Colm. That was amazing. Thank you. All right, Rajiv had a take back question. Is pH controlled better than unreal? Okay, you've answered it. And Kurt says, you mentioned pH and CO2 as influences on PVR. Which one is it? Of course, it has to come from Kurt, right?
Well, you probably already know the answer to that, Kurt.
Kurt, yeah, you can unmask yourself. We'll let you do that.
Well,
Yeah.
Look, I think even and it's not very common, but even in physiology books, there is like two camps. Isolated pulmonary vascular valuature it's more pH, but in a living creature, I'm not quite sure. So I was just very curious about your perception and reading all this literature about it. Which one do you think is balancing the most in our NICU population?
Yeah, I think when it comes to some of the PVR, it may well be the pH. Maybe when it comes to control of breathing, there's also reasons to think that the pH might be even also very important compared with the PCO2. I know that a lot of our babies with BPD can often end up with high bicarb levels if they're getting lots of Lasix, for example, or diuretics. and then I think that's one of the reasons that people tend to push the CO2 higher in those infants, because they have so much compensation that they're trying to get the effect of the little mild acidosis. But it's very controversial, because then you could potentially increase the risk of developing pulmonary hypertension, and it's different. And then is the bicarb high just because the chloride's low? There's lots of little questions like that. I don't think we fully know the answer to.
No, it's just, bicarb came in, was standard of practice when I was training, and then it was removed. And, do you think there will be a time that it comes back for this particular reason, to balance the CO2 versus the pH?
Yeah, I mean, I know anecdotally in our unit, we provide a little bit of acetate in our line fluids to avoid the need for bicarb boluses early after birth, and that's also so that we can keep that CO2 in a 40 to 60 type of range, and practice a little bit of more gentle ventilation, hopefully. Because if the pH is less than 7.2, you'd have to worry about how does the body start to function if you get down into lower pHs. So yeah, generally we probably are kind of giving babies a small amounts of acetate quite early after birth, to try and avoid them getting too acidotic. But again, it's anecdotal. I don't think anybody knows the evidence from, not really good evidence from randomized trials about that.
Do you think the threshold for hypercapnia or any the CO2 level will change as the child gets older? Well,
Yeah,
it's not a specific marker at each, the PaCO2 at every stage of their lives will not be the same, right?
So yeah, I think how we interpret the data at UAB is that we use transcutaneous carbon dioxide monitors on our babies who are ventilated. And so how we set the limit for the upper limit of the carbon dioxide monitor is we think about what would the pH, at what point would the pH be less than 7.2? And that's our upper limit of our TC monitor. And then we do like 15 or 20 below that for the lower limit. And that's the kind of range that we use to target our transcutaneous CO2s. So that tends to, as the baby gets older, they start to get more compensation. Naturally, you're usually able to start increasing those limits as the baby gets older and they start to compensate.
Okay, so what about the unventilated, the ones on non-invasive ventilation, Colm?
Yeah, probably one of the helpful things that permissive hypercapnia can let you do is to get more babies extubated. And then if you're not so worried about their pH and their CO2, you can often keep them extubated. And bearing in mind again that CO2 is I mentioned at the start of the talk that CO2 is a pretty important mechanism that helps babies to breathe and decrease their amount of apnea that they have. So I think one of the great things that you can practice with permissive hypercapnia is getting babies extubated and then leaving them extubated if you're not so worried about what the CO2 is.
Okay, thank you. There's a question from Sumil Desai. Wonderful talk, yes. Thoughts on cases with CDH accepting sets in the mid-80s, higher CO2s invariably with lung protection strategies. But unfortunately, this can also enhance pulmonary hypertension secondary to lower acceptable levels of sets. Does nitric oxide work, I guess?
Yeah, but I'm not no expert on CDH, but I know that a lot of the units, again, based on observational data, there's no randomized trial. And based on observational data, a lot of units have switched to a more permissive hypercapnia approach in order to, again, achieve more gentle ventilation strategies. I can't really talk about permissive hypoxemia in that population. I think the randomized trials of nitric oxide didn't really pan out in CDH babies. But again, I'm no expert on CDH specifically. But I think in babies with pulmonary hypoplasia and CDH is one of those groups. We definitely favor lower volumes, higher rates, permissive hypercapnia strategy, but anecdotally.
And how would we design a study to answer that?
You need a lot of units probably because CDH is not so common. So probably a large multi-center trial, and again, probably trying to figure out what are the short-term outcomes that matter, or is there some sort of continuous outcome that you can pick that's relatively important to families and to clinicians, because you're not going to be able to do a trial of probably not going to be able to do a trial anytime soon of 1,000 infants with CDH.
Migraine with that one. There's Dr. Hayes' question. What would you accept as a CO2 level or acceptable hypercarbia if the extremely premature baby is intubated?
So yeah, again, we generally will target 40 to 60 in our first week, on the basis of these randomized trials. That is, though, still influenced by what the pH is. So if you have a baby who's kind of running a mild metabolic acidosis, and you can't let this, if you had a pH of 57 and that will give them a pH less than 720, well, maybe then we'll have to run 40 to 55, or even sometimes we'll have to even lower the limits and practice closer to normal capnia if the baby has a lot of acidosis going on. But that doesn't meet our threshold to get bicarb. So I think generally our limit of CO2 is guided by our pH.
CO2 guided by pH. So you would accept a CO2, for example, of 70 if the pH is okay?
If the pH is okay, we're not going to be so worried about a pH. If the pH is
Okay.
7.20, that would rarely happen, though, because most of the kids will have a mild acidosis, metabolic acidosis as well, and won't have compensation yet. But so it'd be pretty rare for them to have enough bicarb to allow for a pH or to allow the CO2 to be above 60 in the first few days.
And if the baby was unintubated, like 32, 34 weeks old or something, brewing bad BPD, when would you intubate the baby?
Yeah, we generally try to, the support trial probably provide, and the high five, the one I talked earlier on, they probably provide some guidance on that. Again, the pH less than 7.2
pH.
Is probably going to be the key determinant. Along with earlier in the course, you're probably looking at CO2s less than 65, like or more than 65 for intubation, like the support trial used. FiO2 requirements vary according to different studies. And probably the older preterm baby that you're describing there, you could probably, nobody really knows what the upper limit of FiO2 is for intubation.
Yeah, lots of unknowns. And Kurt's asking, how can we optimize group separation? Because some of the trials were pretty tight.
Yeah, it's a great question. I think when you start getting to CO2s above 50s, into the 50s, it's pretty hard to make what's really interesting when you try to wean these babies is that it's really hard to make a baby CO2 sometimes if they're breathing spontaneously go up into the 60s and 70s, because when you wean them, I'd say 90+% of the time their CO2 is not going to change. And so what happens is you just can keep weaning them, and then they just keep breeding, and then eventually you just extubate them. And then they'll keep their CO2 around 55 to 60 most of the time. I mean, some of the babies that stayed intubated in our trial did end up with CO2s in the 70s, 60s and 70s, like with the intended target range, and they were probably the sicker babies that were left over from the rest of the babies who were able to get extubated earlier, and they just kept their CO2s in the 50s.
Right. Okay. Thank you. Any other questions? Or Madhu says, pediatric respiratory physicians, like PCO2s below 55 in COD before they let them go home. Any suggestions or key evidence to share to convince on pH controlled hypocapnia?
Yeah, I mean, I think the trials that we're discussing are probably the best evidence for talking with we have the same issue on our side with the pediatric pulmonary physicians sometimes being worried about higher CO2s in the infants with BPD, and there's probably a lack of high quality evidence really for CO2s in infants with BPD, like I mentioned. But again, I think considering the pH and the CO2, together. And we sometimes make the point that look, it's once the baby's extubated or on a cannula, we have no control over their CO2. There's absolutely zero that we can do to make their CO2 get better. And we just have to accept that probably the baby's going to have a higher CO2 until their lungs get bigger, which will happen over time.
Any information?
Do you have to stay in hospital for that long? I don't know. Say it again, Julie.
Any information on BPD baby CO2 at home?
Yeah, I don't think there's any information on what's a normal CO2 for babies after they go home. It's a good question.
Okay, that might be a research project.
Yeah, it could be a research project.
Could be a research project for a young, keen person. All right. So, so no other questions. I know it's incredibly late in Alabama now, almost like 11.
Almost 11, yeah.
Way past your bedtime. That was a wonderful talk. If everything is okay on the recording, Colm, are you okay if we upload it to our YouTube channel? I'll flick it to you to have a look first to see whether you're happy with it.
Yeah, absolutely.
That would be amazing. Okay, thank you. Thank you so much for dialing in so late at night. And thank you everyone for joining us online. Next week, Kurt has something else for us.
Cheryl Hartlesby is going to talk about PDA trials, how to interpret all this new data, and what's the next steps in PDA, similar with CO2. And what is the next step? And so many steps to take. Yeah.
It'll keep us working.
All right.
Thank you so much. Okay.
Thanks, Colm.
All right. Good night, Colm.
Yeah,
thank you.
Also
Bye, everyone. Bye-bye.
Bye.